Imagine being told that you have a disease that, well, it behaves almost exactly like cancer.
Mm.
Like the cells just go rogue. They
Wow.
completely refuse to die when they're supposed to. They invade your healthy organs, spread all over your abdomen, and just create this localized environment of chronic inflammation.
Right.
But then, after running all the tests, your doctor just looks you in the eye and says, don't worry, it's technically benign.
Yeah, it is a profound medical paradox.
Yeah.
We're talking about a condition that mimics malignancy in almost every biological way, yet it just doesn't carry that cancer label.
Right. Which,
And for the roughly 10% of women of reproductive age who are living with it, that paradox doesn't really offer much comfort.
no, I can't imagine it does.
Right. It usually just breeds this really deep, lingering anxiety.
Yeah. And we are, of course, talking about endometriosis.
Exactly.
And its sort of lesser-known relative, adenomyosis.
Mm-hmm.
Because for decades, the link between these conditions and actual cancer has been this really murky gray area.
Very murky.
Filled with, terrifying headlines and very little actionable clarity for the patients.
Right.
So our mission today is to finally cut through that fog. We're doing a deep dive into a really monumental Swedish nationwide cohort study. This was published in 2026 by Moberg and colleagues.
Yes.
And they looked at a data set of over 4.2 million women over 2 decades.
It's massive.
Yeah, 4.2 million. Just to figure out what is statistical noise and what is biological reality when it comes to the risk of gynecological and breast cancers.
And the sheer scale of that data set is really what makes this paper so powerful.
Yeah.
Because when you track 4.2 million people over 20 years, you aren't just looking at isolated case studies anymore.
Right. It's not just anecdotes.
Exactly. You are watching the fundamental biology of a disease play out across an entire population.
Okay, so before we go deeper, let's just make sure we are all on the same page with the terminology here.
Sure.
So endometriosis is when tissue that is, well, similar to the lining of the uterus, it grows outside the uterus. So on the ovaries, the fallopian tube, sometimes even the bowel, right?
Yeah, exactly.
But the study also includes adenomyosis. So how would you define that for us, just simply?
Yeah, so if endometriosis is the tissue growing completely outside the uterus, adenomyosis is that same type of tissue growing inward.
Inward.
Right? It embeds itself deep into the thick, muscular wall of the uterus itself.
Oh, wow. Okay.
Yeah, and both conditions share that core mechanism, right? It's misplaced tissue that responds to your monthly hormonal cycle.
So it bleeds.
It bleeds, and it causes severe pain and inflammation because that blood just literally has nowhere to escape.
Okay, let's unpack this, because we have to start with the raw numbers that just sort of jump off the very first page of this study.
The initial data, yeah.
Because, frankly, they are alarming.
Very.
So the researchers isolated about 49,133 women in Sweden diagnosed with either of these conditions between 1997 and 2018.
Mm-hmm.
And they looked at the cancer rates in the exact same calendar year that these women got their endometriosis diagnosis.
Right, that same year window.
Yeah. And the numbers showed a 40-fold increase in ovarian cancer.
Yes.
The study uses this term, the standardized incidence ratio, or SIR, placing it at 39.6.
So let me actually translate that SIR metric real quick.
Yeah, please do.
Because it's really the mathematical backbone of this entire study. So think of a SIR of 1.0 as the baseline.
Okay.
That's the normal expected rate of cancer in the general population.
So 1.0 is normal.
Right. So if the SIR is 2.0, your risk is double.
Got it.
Now, in that first calendar year of an endometriosis diagnosis, the SR for ovarian cancer was 39.6.
Which is almost 40 times the expected rate.
Exactly. And for endometrial cancer, the SIR was 47.
Okay, wait, a 47-fold increase overnight.
I know, it sounds...
I mean, biology doesn't work that fast, right?
No, it doesn't.
Is this like taking your car in for a weird engine noise, and while the mechanic is poking around under the hood, he finds a massive, totally unrelated brake line issue that you never would have noticed otherwise?
That mechanic analogy actually works really well, but with a slight twist.
Okay.
Because in this medical scenario, the engine noise and the brake issue are often causing the exact same physical symptoms.
Oh, I see.
Yeah. The medical term for this phenomenon is detection bias.
Detection bias, okay.
Right. So these massive spikes in the data, they aren't happening because a totally benign endometriosis lesion magically mutated into stage 4 cancer in a matter of weeks.
It's just the timeline of discovery then.
Exactly. And what's fascinating here is how identical the clinical presentations actually are.
Really? Like the symptoms are the same.
Very much so. Both severe endometriosis and early-stage ovarian or endometrial cancer, they both thrive in a chronic inflammatory environment in the pelvis.
Wow, okay.
So a patient will present with severe bloating, really intense pelvic pain, maybe abnormal bleeding.
And so the doctor obviously starts looking for a cause.
Right. The physician starts aggressively investigating. So they might go in for surgery suspecting a tumor, and while they are operating, they discover all this extensive, undiagnosed endometriosis. Or, alternatively, a surgeon goes in to clean up endometriosis lesions and unexpectedly biopsies a piece of tissue that comes back malignant.
So the disease didn't trigger a spontaneous cancer out of nowhere. It's just that the patient finally gained access to the upper tiers of the healthcare system.
Yes.
And the intense diagnostic spotlight basically caught both conditions at the exact same time.
Exactly. The diagnostic investigation for one essentially unmasks the other.
Right.
And if you don't account for that artificial spike in that first year, your data on the long-term actual biological risk is entirely compromised.
Which means the only way to figure out what endometriosis is actually doing to the body over a lifespan is to just throw that first calendar year in the trash.
You have to. Yeah.
You have to look past the initial shockwave of the diagnosis and examine the subsequent decades.
And when Mupberg's team did that, the risk numbers plummeted from those terrifying heights we just talked about.
But they didn't drop completely back down to normal, right?
No, they didn't. They remained persistently elevated.
Okay.
So looking at epithelial ovarian cancer in the years following an endometriosis diagnosis, the overall risk sits at nearly double that of the general population.
Which would be an SIR of almost 2.0.
Right. It's an R of 1.9.
Okay, pause for a second there. Epithelial ovarian cancer. I throw that word around a lot, but what does epithelial actually mean in this context?
Good question. So epithelium is just the cellular layer that covers surfaces in the body.
Like a skin layer.
Kind of, yeah. In this case, we're talking about the cells on the outer surface of the ovary itself.
Oh, I see.
And most ovarian cancers actually develop from those outer surface cells.
Okay, that makes sense.
But the study gets much more granular than just looking at that outer layer broadly. It actually breaks down the risk by specific tissue pathology.
And that's where we see the real culprits, right? The subtypes.
Yes, the subtypes.
Because the study shows the risk for clear cell ovarian cancer is almost 8 times higher
Right.
than SAR of 7.7.
Yep.
And for the endometrioid subtype, it's nearly 3 times higher at 2.8. Why those two specifically?
Well, both clear cell and endometrioid ovarian cancers have really deep biological ties to the exact type of tissue found in endometriosis.
Oh, interesting.
Yeah, it suggests that over decades, the chronic localized inflammation that's caused by these bleeding endometriosis lesions, it creates this sort of toxic environment.
Like a constant state of damage.
Exactly. The constant cycle of tissue injury and repair on the surface of the ovary likely forces those cells to divide more rapidly.
Right. And the more they divide.
The more they divide, statistically, it just increases the chance of a genetic copying error that eventually leads to cancer.
Here's where it gets really interesting to me.
Oh, yeah.
I can totally wrap my head around ovarian tissue being damaged over time. Like, the ovaries are quite literally in the blast zone of that pelvic inflammation.
Right there, right there.
But the study also found that breast cancer risk is slightly, but persistently elevated across almost all age groups in the years following an endometriosis diagnosis. I think the SR is 1.2.
Yeah, 1.2.
So is the endometriosis itself somehow traveling through the bloodstream and setting up shop in the breast tissue?
No, no. Biological spread of endometriosis to the breast is exceptionally rare. It definitely wouldn't account for a population-wide statistic like this.
Okay, so what's driving it then?
The researchers actually point directly away from the disease itself and toward the treatment of the disease.
The treatment.
Yeah, endometriosis is fundamentally fueled by estrogen, right?
Right.
So the primary non-surgical way that we manage that intense pain and try to slow the growth of the lesions is by manipulating the patient's hormonal landscape.
By suppressing their natural cycle.
Exactly.
With birth control pills, progestins, or other hormone therapies.
Yes. And breast tissue is profoundly sensitive to exogenous hormones.
Meaning hormones introduced from outside the body.
Right. So keeping a patient on a continuous, steady state of hormonal therapy for a decade just to manage their pelvic pain, it means their breast tissue is under a different type of continuous stimulation.
Oh, wow.
So the researchers theorized that this lifelong medical intervention is actually what bumps the breast cancer risk up by that factor of 1.2.
Wow. Okay, let me stop you there, though, because whenever we start talking about, 8 times the risk for cancer or elevated breast cancer risk from birth control, it is really easy for a listener to just spiral into sheer panic.
Oh, absolutely. It sounds terrifying.
So we need to clearly separate relative risk from absolute risk right now.
This is perhaps the most crucial takeaway from the entire analysis.
Yeah,
Everything we just discussed, the 1.9 SIR, the 7.7 SIR, all of that is relative risk.
right. It's a multiplier.
Exactly. It's a multiplier. You are twice as likely or 8 times as likely to develop a disease compared to the person sitting next to you. But if the disease itself is incredibly rare to begin with, multiplying that baseline risk still results in a very, very small number.
Right. So what is the actual absolute baseline we are multiplying here?
Okay, so the lifetime absolute risk of a woman in the general population developing ovarian cancer is roughly 1.3%.
1.3%. Okay.
So if severe endometriosis doubles your risk, your absolute lifetime chance of getting ovarian cancer becomes approximately 2.6%.
Okay, my anxiety just dropped considerably.
Right.
Because we're saying that even with a confirmed severe endometriosis diagnosis, a patient still has a greater than 97% chance of never developing ovarian cancer in their entire lifetime.
Exactly. A greater than 97% chance of remaining completely free of ovarian cancer.
Wow.
And this massive difference between relative and absolute risk is exactly why the authors of the study explicitly warn against radical preventative surgeries.
Like removing the ovaries.
Right, prophylactic salpingo-oophorectomy. The surgical removal of healthy ovaries and fallopian tubes is absolutely not justified purely as a cancer prevention strategy for endometriosis patients.
Well, yeah, because throwing a 30-something woman into instant, irreversible surgical menopause causes massive, immediate issues for her, bone density.
Bone density, cardiovascular health, cognitive function.
Right. You don't trade those guaranteed health crises for 2.6% risk of cancer.
No, you definitely don't.
So how do doctors manage this? What's the practical move if surgery is off the table?
The clinical recommendation actually relies heavily on oral contraceptives as a highly effective dual-purpose tool.
Okay.
Because extensive epidemiological studies show that long-term use of the birth control pill significantly lowers a woman's lifetime risk of developing ovarian cancer.
Wait, hold on. I have to push back here.
Okay.
You just told me 3 minutes ago that the study theorizes hormonal treatments are the exact reason breast cancer risk is elevated by 20%.
I did, yes.
Now you're saying doctors should prescribe those same hormones to lower the ovarian cancer risk.
Yep.
How is a physician, or let alone a patient, supposed to navigate a paradox like that?
It is the ultimate clinical catch-22.
Seriously.
But it perfectly illustrates why chronic illness management is never a one-size-fits-all algorithm.
Yeah, that makes sense.
The physician has to sit down with the patient and weigh their specific individualized risk profile.
Right. So, if a patient has a strong family history of breast cancer.
Exactly. Then maybe continuous oral contraceptives aren't the best route for them.
But for someone else.
But for a patient whose primary threat is aggressive endometriosis lesions basically destroying their ovaries, the protective effect the pill offers against ovarian cancer, while simultaneously treating their daily debilitating pain.
It far outweighs the breast cancer risk.
Right. It far outweighs the slight 1.2-fold relative increase in breast cancer risk. It is a constant, ongoing calibration of risk versus reward.
But all of these statistics, the spikes in ovarian cancer, the slight bumps in breast cancer, they assume this linear relationship between having this disease and getting cancer.
Right.
But as I read further into this data, I saw a mathematical plot twist that just seems to break all the rules of logic.
Oh, you mean the protective associations?
Yes. Let's talk about the plunges.
Let's do it.
Because in the years following an endometriosis diagnosis, the risk for endometrial cancer, which is cancer of the lining of the uterus itself, it doesn't go up.
No, it doesn't.
It actually drops to almost half the normal rate.
Mm-hmm.
The SR is 0.6, and it doesn't stop there. Cervical cancer risk also decreases, dropping down to an SR of 0.7.
And on a purely biological level, it seems totally counterintuitive.
Totally.
Yeah.
You have a disease defined by highly active inflamed endometrial-like tissue.
Right.
You would assume the risk for actual endometrial cancer would skyrocket.
It would.
This is where I really struggle with the mechanism. Does having endometriosis act like a cellular bodyguard?
A cellular bodyguard.
Yeah. Does the immune system get so revved up fighting the endometriosis that it inadvertently destroys early cervical and endometrial cancer cells?
That's a fascinating idea, but...
Or is this just a side effect of wearing a helmet?
Wearing a helmet.
Yeah, wearing a bicycle helmet technically protects your head in a crash, right?
Right.
But maybe the primary reason your injury risk drops is just because wearing a helmet makes you drive your bike a little slower and more carefully.
Okay, I like that. The bicycle helmet is a good foundation, but let's take it a step further.
Okay.
It's not just that you are driving slower, it's that the mechanic occasionally takes your bicycle away entirely.
Wait, walk me through that.
So if we connect this to the bigger picture, the drop in cancer risk has absolutely nothing to do with a biological immune shield.
Oh, really?
Yeah, it is entirely driven by aggressive medical intervention and human behavior.
Okay, explain that.
Let's look at endometrial cancer first. Where does it grow?
Well, in the uterus.
Right. And many women with severe intractable endometriosis and especially adenomyosis, they eventually reach a point where no medication stops the agony.
So they opt for surgery.
Yes. The ultimate definitive treatment they choose is a hysterectomy.
The surgical removal of the uterus.
Exactly. You cannot develop endometrial cancer if you no longer possess an endometrium or a uterus.
Wow. Of course.
The surgical treatment for the benign disease physically removes the real estate where the malignant disease would have eventually grown.
That is wild. But, okay, that explains the drop in endometrial cancer perfectly, but
Right.
what about cervical cancer?
Right.
Because unless the patient had a total hysterectomy that also removed the cervix, they are still biologically vulnerable to it, right?
They are biologically vulnerable, yes, but clinically they are hypermonitored.
Ah.
Women battling a severe chronic pelvic condition practically live at their gynecologist's office.
I can imagine.
They are subjected to far more frequent pelvic exams and ultrasounds than the average population.
Right. Constantly being checked.
And cervical cancer is almost always preceded by cervical dysplasia,
Which is?
slow-growing precancerous cellular changes caused by HPV.
Okay, got it.
Because these patients are constantly in the stirrups being examined, their doctors catch and freeze off those precancerous cells years before they ever have the chance to mutate into invasive cervical cancer.
So their misery actually buys them hypervigilance. The system is watching them so closely for one problem that it accidentally saves them from another.
That's exactly it. But, the study highlights a much more sobering sociological theory alongside that monitoring, too.
Really? What is it?
Well, the researchers note that severe endometriosis frequently causes dyspareunia, which is the clinical term for agonizing pain during sexual intercourse.
Oh, wow.
Yeah, and this chronic pain can lead to a significant decrease in sexual activity over a patient's lifespan.
And less sexual activity.
Inherently lowers the patient's lifetime exposure to new high-risk strains of HPV.
I see.
And less HPV exposure directly translates to a lower long-term risk of cervical cancer.
Man, so what does this all mean? When you step back and look at the drops in cervical cancer, the protective effects of hysterectomies, and the side effects of hormone treatments, this study isn't really a pure map of biological cancer risk at all.
No, it's not.
It's basically a reflection of how this disease completely hijacks a person's life.
Exactly.
Their surgeries, their constant doctor visits, even their physical intimacy.
It is a map of the patient's journey through the healthcare system just as much as it is a map of their cellular biology.
Right. And that map brings up a massive mathematical red flag in the methodology of this 22-year study that we really need to address.
The iceberg problem.
Yes. Let's talk about the iceberg problem.
Let's do it.
Because the researchers pulled their data from the Swedish National Patient Register. Over 2 decades, they found diagnosis codes for roughly 49,000 women out of a total population of 4.2 million.
Which is only 1.2% of the population.
Exactly, 1.2%. But earlier, we established that the known global prevalence of endometriosis is around 10%. So if the registry only caught 1.2%, we're missing nearly 9 out of 10 women who actually have this disease.
It's a huge gap.
Are we just looking at the tip of the iceberg here? Like, is this study only capturing the absolute worst-case scenarios?
You hit the nail on the head. This statistic inadvertently exposes the massive systemic crisis of delayed diagnosis in women's health.
Because it's so underdiagnosed.
So underdiagnosed. The women who actually made it into this national registry likely represent only the most severe clinical phenotypes.
Meaning the worst of the worst.
Right, the most aggressive, physically destructive versions of the disease. Because to get a code in that registry, they had to be in so much pain that they required hospitalization, specialized outpatient care, or invasive abdominal surgery.
Right, because historically, the only gold standard for diagnosing endometriosis was a laparoscopic surgery. Right?
Exactly. A surgeon had to physically cut into the abdomen, locate the lesions, and biopsy them. So if a woman's primary care doctor simply listened to her symptoms, handed her a prescription for birth control, and told her severe period pain was, quote unquote, just part of being a woman
Which happens all the time.
all the time, then she managed her disease at home, she never received an official diagnostic code, and she never made it into this data pool.
So there is just a vast, undocumented ocean of women beneath the surface. That other 8.8% living with mild to moderate endometriosis who aren't represented in these cancer statistics at all.
Yep.
And I guess their inclusion might actually drive these relative risk numbers even lower.
It absolutely could. And this raises a really important question about how clinicians must use this data today.
What's the takeaway for them?
Well, the authors of the study issue a clear mandate. Physicians must maintain a higher index of suspicion for breast and ovarian cancers in their endometriosis patients.
Okay, so they can't just wave it off.
Right. A doctor cannot simply dismiss new pelvic pain, sudden bloating, or unexplained weight loss as just another endometriosis flare-up.
Right, because it could be something else.
Exactly. They have to remember the elevated statistical risk and investigate with an ultrasound or an MRI.
And it shifts a burden onto the patients as well, doesn't it?
It really does.
If you have endometriosis, you can't just focus on surviving your daily pain. You kind of have to manage the lifelong surveillance of your body.
Unfortunately, yes. The study specifically urges these women to be proactive about their breast cancer screenings.
Right.
In Sweden, that means demanding your mammogram right at age 40 without delay.
Which is great advice, because knowledge is really only valuable when it's actively applied.
Exactly.
Knowing that your specific risk for clear cell ovarian cancer is slightly elevated shouldn't paralyze you with fear.
No, not at all. It should empower you to not ignore weird symptoms.
Right.
It gives you the evidence you need to demand the follow-up scan when a doctor tries to brush you off.
Right. So we've covered the diagnostic shockwaves, we've talked about the long-term realities, and the massive flaws in how women's pain is recorded.
We have.
But before we wrap up this deep dive, I want to circle back to a fleeting, easily missed detail buried in the introduction of this study.
Oh, I know what you're going to say.
A detail that honestly feels like peering into the future of medicine.
You are referring to the molecular sequencing data.
Yes, I am. The researchers casually cite this recent genetic discovery that completely blew my mind.
It's wild.
They noted that about 20% of epithelial ovarian cancers and deep infiltrating endometriosis lesions share the exact same somatic cancer driver mutations.
Yeah, that is a huge finding.
Let's clarify somatic for a moment, just for the audience.
Sure. So we aren't talking about genes you inherit from your parents, like the BRCA mutation.
Right, it's not inherited.
No, a somatic mutation is an acquired error. The DNA inside a specific group of cells spontaneously mutates during your lifetime.
It essentially rewrites its own programming.
Right, to aggressively multiply and ignore the body's natural signal to self-destruct.
Which is literally the biological engine of cancer. And we established at the very beginning of this conversation that endometriosis acts like cancer.
It invades, it spreads, it refuses to die.
Right. And the genetic sequencing proves that it is literally using the exact same mutated DNA engine as a malignant tumor to achieve this.
Yes.
Yet, as we've discussed, it almost never makes that final fatal leap into a true metastasizing cancer.
It's incredible. It possesses the genetic code for malignancy. But something in the local environment of the pelvis, or some hidden line of cellular programming within the endometriosis itself, it acts as a biological brake pedal.
Wow.
The engine is redlining, but the car refuses to crash.
The car refuses to crash.
Yeah.
And that leaves us with a truly provocative final thought to mull over.
Yeah.
Because right now, endometriosis is viewed merely as a burden, a chronic, painful, historically overlooked disease.
Very much so.
But if cellular biologists can figure out exactly how these endometriosis lesions utilize these fierce cancer-driving genetic mutations without ever becoming fully malignant.
Which is the holy grail.
Right. Could this disease actually be the key we've been looking for?
It's a profound question.
Could studying the biology of endometriosis eventually provide the exact blueprint we need to force true deadly cancers to stop metastasizing?
It really makes you wonder.
Could the disease that breaks all the diagnostic rules ultimately be the cure that fixes the system entirely?